Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hesham Hasabala.
Hey everybody. Hi, this is Hesham Hasabala with Healthcare Musings. I am super delighted to finally get into the video space again after a long time, and I am delighted to have with me a very special guest, the first in my series of Great Minds in Medicine. And I'm going to be interviewing a number of pretty prominent people in the healthcare field. And I am super delighted and honored to have Dr. Rob Zipper as my first guest in this series. He is the Chief Medical Officer for Physician Advisory and Health Policy for Sound Physicians. Full disclosure, Sound Physicians, everyone knows, is my employer. And who better to ask about these things than Dr. Zipper? He and I have worked together for many years. He's a wonderful friend and colleague, very knowledgeable, very helpful. And I think I wanted to kind of talk about back in a few weeks ago, I published a podcast episode about the CMS rule changes, not rule changes, but the the reimbursement changes. And all I could say was WTF, and he kind of helped me understand why. And so I think it's be very helpful for him to explain to us what happened, what's going on, and if he's able to, what we can do about it. So welcome, Dr. Zipper. So happy to have you at Healthcare Musings.
Thank you, Hesham. I really appreciate being here.
Oh, I'm so happy that you're here. So what the WTF? What's the deal? Come on.
Well,
come on.
Yeah.
I mean, it's in the beginning, you could see how some people could say this was greed, and you physicians just want to make more money, and now you're 3% less, so it takes you longer to buy your Porsche. And it's not about that. It's about practice sustainability. I mean, it's just, and I help run practices all across the country, and it's our costs are going up. Salary inflation for physicians and APPs is double digits. And reimbursement is the only way we can pay for that, and it keeps going down. It's not sustainable. WTF, man, what's going on?
Well, so there's a lot of history here, and in the immediate short past, the proposed rule for the Medicare physician fee schedule, which is what you're referring to, I think that's what gave you that expression. I think that gives people that expression. The proposed and final rules, it's a rulemaking cycle. Every year there's a proposed rule put out sometime around July 4th by CMS. And then it gets finalized late November, early December, sometime in that time frame. And there is a public comment period. That's the reason for the proposed rule. Certain parts of that proposed rule, actually just the early parts, if you actually read the rule, these things are typically 1,200 to 1,400 pages, something like that. And they're not quite as painful as reading a document that long would sound, other than the fact that they, for some reason, publish them in Times New Roman and don't do a good job indexing them. That does not make it easier. But,
why would they make it easy? Why would they make it easy? Why would they?
It'd be nice if it was indexed, that I will say. It's hard to find certain things until you get familiar with the anatomy of the document and figure out how to search for terms and whatnot. But early on, there's always a discussion of what's called the conversion factor. The conversion factor is it's a mathematical figure that goes into keeping what's called budget neutrality. Healthcare costs have been going up for 40 years, 50 years, and on a trajectory to be unsustainable for the last, say, 15, 20 years. And so the conversion factor helps keep healthcare costs relatively constant for CMS. Okay, so this doesn't really apply to commercial, although commercial payers tend to follow. So from a provider standpoint, it does affect both. If you think about it over time, the population of seniors is growing, the population of doctors is growing, and other healthcare professionals. And so as more and more services are billed, there is only so much money to go around. So what the conversion factor does is that it modifies, in every case it reduces, but it modifies the value of an RVU. If there are more RVUs, each RVU has to be worth a little bit less each year. That's really the fundamental change.
And for you, and just so that people can know what you're talking about, what is an RVU?
Yeah,
I mean, I
thank you.
kind of know inherently what an RVU is, but kind of
Yeah,
what
and you
is
and
that?
I, we talk about these things as if everyone understands what we're talking about. Thank you. So it stands for relative value unit. There's a long history behind the creation of the RVU scale, and been 45 years or something. I don't know the exact timing of that, but each procedure or visit that a physician or APP has with a patient is assigned a certain number of RVUs. Technically, they're weighted RVUs, and we don't need to get into all the technicalities of that. But each procedure, be it coronary bypass surgery or a visit to your doctor in a clinic or an urgent care, has a number of RVUs that's associated with that. It varies a little bit by the complexity of the patient care involved and so forth. But generally speaking, that conceptually, I think that's what's important. Some things are a fraction of an RVU, like interpreting an EKG is a very, very small fraction of an RVU. It's actually more expensive to bill it and try to collect for that than it is to actually, because I think it's like, I don't know, it's $6 or something like that. It's like 0.1 or 0.15 RVUs.
Yeah.
But then others, some large surgeries also include post-op care for up to 90 days. And those can be 20 or more RVUs. And so it does vary quite a bit. Yeah.
And is the reimbursement then the conversion factor multiplied by the RVUs? Is that what Medicare pays?
There are, in a simple way of thinking of it, there is. There are also other things that go into modifying that, like what geography you happen to be practicing in, something called the Geographic Price Control Index. But the gypsy, it's also referred to as, but, and there are also practice expense variables that go into various things. So for an office practice, there are practice expenses that need to be reimbursed as well. Office supplies for a particular procedure are often included in practice expense. In the hospital, we don't typically see that. For the kind of work that you and I do, but surgeons certainly can. The PE expense, as it's called, can include prosthetic joints. So, patients that are getting a knee replacement, the implant itself, those are not inexpensive and need to be covered as well.
Okay, yeah. So the problem is, again, the costs keep going up. I mean, everyone's demanding higher salaries. The marketplace is what it is.
Weight loss drugs alone are likely to impact the CF over time, the conversion factor over time.
So then why I just don't understand, if my understanding is correct, that the clinician, the provider, I hate the word provider, but the healthcare deliverer, the healthcare professional is 4 cents out of every healthcare dollars. Why are they always doing the savings on our backs? It seems like that way. Correct me if I'm wrong.
I can understand.
What is it about? I mean, 96% of the healthcare dollar is going elsewhere, and every time they keep coming to us and giving us less.
It can feel that way. I don't think it's a concerted effort. I think it's more a matter of what the existing policy is and the fact that budget neutrality affects the Medicare physician fee schedule, and it does not impact hospitals and hospital reimbursement or other areas of healthcare. As with anything, even in our very polarized political times, even if we weren't so polarized, this would still be an issue. The healthcare expenditures were projected to be 22-25% of GDP. That has slowed a little bit, the growth in the percentage of GDP that goes to healthcare. But the more you spend, the more a country spends on healthcare, the less they're spending on infrastructure, education, everything else that a government needs to fund. And so there is no such thing as like limitless money to spend. Anytime Congress has something that is going to increase expenditures, really of any kind, it's very difficult to get something pushed forward. I do think now, more than any time I've seen it in my career, there is more focus on the roughly 26% pay cut physicians have taken over the last 20 years through not getting upward adjustments for inflation alone. So it's not that, it's not just cuts. We've actually had, the fact that there is no inflationary adjustment has meant a very large pay cut across the board.
Yeah.
Yeah. So, I mean, I think there is more focus on that. The AMA is, if you asked any AMA staffer what their number 1, 2, and 3 issues are that they're fighting for healthcare, physicians in particular, but healthcare in general, it's reimbursement. Yes, they're focused on prior authorization and some other issues in the Medicare Advantage space, but it's mostly reimbursement.
Yeah, I mean, and it's now I understand when they threaten. Well, we're threatening the care of seniors, but if you're running an office practice and you're running every single patient at a loss, and the commercial insurers are following suit, right? So they peg their reimbursement to Medicare, to CMS, and so as CMS goes down, commercial goes down. Eventually, you just can't run a practice anymore. I mean, we saw that with the Change Healthcare cybersecurity incident. Practices don't even have 1 week's worth of cash on hand. So, I mean, at some point, we're just going to throw up the towel and just say, forget it, and big groups like ours are not immune to that kind of financial pressure.
No, not at all. Yeah,
it's just baffling every single time.
I mean, you could argue that employers, I don't think we are unique in this respect in any way. It could be a health system that's an employer, although they do get adjustments upward. Any employer or large medical group is at risk of having physicians. Let me take a step back. If you're in a private practice, my first job out of training was a practice with 7 physicians, a rheumatologist, 2 pulmonary critical care guys, and the rest of us were internists.
So was mine.
Yeah, we had an outpatient, inpatient practice, and if the practice collected less money, you took home less money, and there was just a recognition that was the way it was. When I left that practice and became a hospitalist, I doubled my income and I worked half as much.
Yeah.
And so, which is insane to think that that's even possible with the same training and credentials, same site, et cetera, same hospital. I think that was, there was a recognition that payment was going down and was likely to continue. And the practice I joined after moving to where I live now was a larger multi-specialty group, 75 or so physicians, a few APPs at that time. There's more now, but that practice, while I was there, decided to stop taking traditional Medicare. And they didn't do that for long, but they stopped for 8 months. I think they later realized that it was driving specialty care, like the specialists that were in that practice were not as busy, and so they actually, for them, when it actually came down to it, the economics just barely favored continuing. But that was almost 20 years ago, and it's definitely gotten worse.
Yeah.
To my knowledge, they still do see traditional Medicare, but I'm sure that's a consideration that they talk about from time to time.
Yeah, I mean, same in my practice. I had to work harder and to get the same amount of money before I switched practices, and now I'm with my current employer.
Yeah.
I was working harder every single year to earn the same.
Yeah.
Reimbursement kept going down, but everything else going on. I mean, it's just so. Again, it's not about physician greed. Is there something to do about it? Is it we're stuck? They have to raise taxes to get more money. I mean, is there a remedy? I mean, I saw a report. I didn't get a chance to read it, from the Senate Finance Committee about physician reimbursement from Medicare. I think, like you're saying, there is recognition on the part of lawmakers that this is not sustainable. And if you want,
I don't know how they could not be aware of it, to be honest. I mean, I think there have been, for 10 or 15 years, there has been this sort of annual cycle of projected pay cuts, and then either partial or complete mitigation of that. Most of the pay reduction that we're looking at for 2025 actually comes because of the expiration of a partial fix from last year. And so, one point I did want to make, though, the proposed rule, this part of the proposed rule isn't actually Medicare making a decision. It's completely statutory. This is 100%, only Congress can change it. So CMS just has to do what they do. They publish it in the proposed rule, which I think is a little confusing to some people because they think, wait a second, these cuts are proposed. They're not proposed. The specific amount is proposed, and it may vary a little bit with further data analysis. Usually it's off by, several decimal points. Like, it's not a meaningful factor by which it's off. But yeah, usually the magnitude is about right. And the AMA publishes, based on all of what they see in the proposed rule, all of the code changes and various other things, they publish a list of, like, by specialty, what they expect the impact to be. Hospital-based specialties have really not favored well over the last, say, 3-4 years. Most of that actually came from a recognition that primary care was undervalued. I don't disagree with primary care being undervalued.
I don't disagree either. I think it's super important.
Yeah, and primary care is among the few specialties that that improve outcomes and lower costs. So patients that actually are plugged into primary care well, generally speaking, have lower cost and better outcomes. But because of the way the conversion factor is and the way that the pie is sort of divided up, if you give one segment of healthcare more, it comes at the expense of everyone else. And I know that SHM, the Society of Hospital Medicine, pointed that out when in 2020, I believe it was, there was a significant increase in the value of the codes that are used for office visits. And keep in mind, these codes are billed millions and millions of times.
Right.
For every patient that gets hospitalized, how many outpatient visits do they have? And many patients are never hospitalized, but also have many outpatient visits in a given year, for example. So these are tens of millions of visits per code, and there are 4 or 5 of them in the outpatient space. So, and that's just for new patients. There's another for patients that are already known to a practice, but all of these codes received very significant increases, and it came at the cost of largely hospital-based providers or specialists that were not billing those codes and are procedural based. We hospital medicine and critical care are kind of caught in the middle of this a little bit. If you're just critical care and don't do a pulmonary outpatient practice, you would not have seen any of that increase because it really didn't apply to any inpatient codes. Yeah. And when the inpatient codes were revalued 2 years ago, there were, among the codes, there were some winners, some losers, meaning some went up, some went down. And on balance, it was pretty neutral. It really depends on what your coding distribution is relative to the different levels. So, but generally speaking, it wasn't favorable. And so hospital-based specialties have taken a significant pay cut on top of the conversion factor issues. In fact, it was through the conversion factor that we got that sort of pay cut, and then didn't see an increase in the values of our codes. Yeah.
And for critical care, they changed the rules about subsequent critical care time.
Yes.
And that was, I mean, it just raised the bar so much higher, and that is a pay cut. They can say, well, we didn't cut the pay, but you made me have to document way more time the second time around to get the same reimbursement. Please don't insult my intelligence. It's a pay cut.
Yeah. Well, so that I think was that wasn't really intentional, and it wasn't directed at critical care. It definitely applies to critical care. That was about what's called the midpoint rule. And CPT, which is an AMA committee, had
always stands for current procedural terminology, right?
Yes. Actually,
it's all the billing codes that we put in, all the 99291, 99292, 92333, all that.
Can't get the camera to focus on it here, but this is the CPT manual. Yes,
and that's from the American Medical
Association. That's an AMA, publication. Okay. Sure. So CPT had put forth something called the midpoint rule. And that says that if the time for a time-based service is, let's say, 30 minutes, that a clinician can bill it if they've exceeded the time by the midpoint. So 30 minutes would have to be exceeded. It'd have to be 16 minutes or more. They don't do half minutes or fractional minutes. But so, 17 minutes, 18, 32, all of those would be eligible to bill that 30-minute code. So what CMS did is they said, wait a second, we never said that we endorsed the midpoint rule. And if there's a time, then that's what the time is. The thing with critical care, though, is that the CPT descriptor, meaning the language that's used to describe a given code for critical care, the time for critical care for the first hour, well, it used to be called the first hour, it's 30 to 74 minutes.
Which is an hour and a half.
Well, 30 to 74. Think about that, though. 30 minutes, right? If you actually are thinking about this conceptually as an hour of critical care, it used to be called first hour. That was changed. But then the midpoint would be 30 minutes. So if you exceeded 30 minutes, and 74 minutes would be 14 minutes almost to the midpoint of that next code, which is a 30-minute code.
Right.
The math actually says that those codes were designed with the midpoint rule in mind. Or it's an incredible coincidence, which I don't believe, right? So I think for critical care, I have little doubt that those codes will get revalued in the next few years. I mean, yes, I am a member of the RUC and I have no influence there. I just suspect that it's going to happen because it's been a long time since they were revalued, and the RUC is on a cycle where they do look at codes. It'll be interesting.
And what's the RUC? What's the RUC again?
Yeah, the AMA has a separate committee called the Relative Value Scale Update Committee, or it's just referred to as RUC, RUC, RBRVS Update Committee. And that group, this is a complicated thing, but that group is comprised of about 30 physicians or clinicians. Many of them are not physicians, actually, and are in nursing disciplines or other. And it is a group that makes recommendations to CMS for what the RVU value of a given code should be. Okay. For example, if there's a new service, let's say there's a new surgical procedure or a change in a procedure, the RUC may take that under consideration and look at the specific procedure, the time that it takes to do it, the complexity, the inherent stress involved in the procedure, and compare it to other similar like codes. It is, by everyone's admission, it is not a perfect process by any means. There's a lot that has been written about how it could be better. I think most of those articles, at least from my experience, have been people that have not participated in the process and I think you just have a harder time understanding it if you weren't directly involved in it. Right. Imperfect as it is, maybe it's the best that exists, and the RUC makes these recommendations.
Okay, so speaking of the AMA, I back in my private practice days, you'd hear people rail against the AMA and, oh my God, this, that, and
yeah.
I became more sympathetic to the AMA during the whole negotiations with the Affordable Care Act, Obamacare. I mean, you may be biased, and at the same time, do you think the AMA is it worth joining? Do you think they are really advocating on our behalf? Now, of course, you're a member of the RUC, and
I am biased, no doubt. But in full transparency, I was not a member of the AMA when I began working with the RUC. I joined because of what I saw. Because the chair of the RUC was wonderful. Zeke Silva is his name, and he was super helpful to me. Even when I started working with the RUC, I was working as an advisor for the Society of Hospital Medicine, meaning I did not have an elected seat. But when the codes that hospitalists and critical care docs may use on the floor, but non-critical care billing, hospital billing for E&M visits or evaluation and management visits, when those were put through the RUC process, no one at SHM had any experience with it. I certainly had zero experience. It probably showed that I had no experience. But It's definitely trial by fire, and but the more I learned about the process and read about different people's opinions about how it's flawed and whatever, I do think that historically there is some structural, the structure of the RUC, the way it used to be in particular, has led to this situation where specialists are paid multiples of what primary care doctors are, or there shouldn't be, in my mind, there shouldn't be a medical specialty that generates $1 million or takes home $1 million a year when others are in the 200,000 range. And I don't, I'm not picking on anybody in particular.
Well, I mean, it doesn't take, you're not in, spine surgery is one that comes to my mind, right? But they're in the operating room 6-7 hours sometimes. And
they are, and there are arguments, longer training is
longer training, and
totally get all that. I just don't know if orders of magnitude are the right differentiation there. You could also make an argument, if you're familiar with the Dartmouth Atlas, that if you want to know where a lot of spine surgeries are done, just look at where a lot of spine surgeons live. The more, consumption or utilization is driven by what a given clinician does, especially on the procedural side. Right. And back surgeries don't have great data behind them. Half get better, half don't. So I'm definitely generalizing, but the Dartmouth Atlas is fascinating in that way. I have definitely practiced in areas that were overserved by certain specialties, and the bar for a patient to get a particular surgery in that community was far lower than it would be in other places, and it does drive some interesting behavior.
Dartmouth Atlas. I'll try to see if I can post a link in the show notes for the Dartmouth Atlas.
Yeah,
and the CPT. The CPT manual? I can put a link there too for the CPT manual.
Yeah, that's something you have to purchase.
Right. But I could just. Yeah. I'll post a link to the
AMA publication. Sure. Yeah. I mean, I think there's probably we could probably find a good description of what CPT is. I mean, I know the AMA has a website or pages that are devoted to what is the RUC, what's the composition of the RUC, CPT as well, I'm sure.
Okay, cool.
And the CPT meetings are actually virtual typically, or you can attend them virtually, and those are open.
Oh, they are. Interesting.
Yeah.
Okay.
Yeah, if you ever have two days and you really want to learn all about it.
And these meetings where they come up with new codes, like new
more often than new codes, definitely new codes do come up, but more often it's a matter of a revision of an existing code. Maybe practice has changed, or sometimes the RUC and the CPT refer things to one another, depending on what they think is needed.
Okay.
For example, there can be, there were some codes that were recently discussed, and without going into detail, but that where just understanding the descriptor between this set of a few codes and this other set of a few codes, there was a lot of overlap and it was confusing, and people using those codes didn't know, wait a minute, should I use this set or that set? And so they asked CPT to revise the descriptions of those to make it more clear between the two. That would be a good example of a revision.
Okay, that makes sense. Yeah. So to circle back, to fix the problem, we have to advocate our elected representatives. Is that correct?
Yes. So just about every specialty society. I don't know about SCCM. You may know.
I reached out to them and they say, "Well, we have and we've done," and it
they do some policy work.
It wasn't very. It didn't put my mind at ease.
Yeah. Well, I know they do have RUC representation that I was not aware of when you and I spoke about that a long time ago. But they have an advisor anyway. But as far as like policy, they probably sign on to letters and whatnot that the AMA writes, and many organizations do that. SHM will sign on to things that they support and agree with. And full transparency, I'm on the board of SHM, so like I probably should disclose that, just not because I think there's any conflict really, but just I should. But the public policy committee is usually the ones who decide, what things SHM should focus on. SHM also do their own, and they also have their own policy arm and will write letters. And many specialties societies have letter writing capabilities. And so if a particular issue comes out, SHM has done letter writing campaigns for issues related to immigration or payment for sure, several other issues that, opiate use, actually, the Xing of the X waiver was largely driven by SHM and very successful. So I think one thing that people can do is look for either their specialty society or the AMA to write letters to their Congress people, their representatives. And they're actually pretty slick these days. All you have to do is put in your name and your address. And just by way of your address, these letters go out to your representatives. And so at the federal level. And so, it may feel like you're just doing something that's a drop in a bucket, but I've definitely seen Xing the X waiver is a good example. I've definitely seen those kind of campaigns bear fruit and raise awareness. It's kind of a numbers game. If you're one person and you write the only letter on a particular issue, maybe you want better regulation of, I don't know, horses or something, whatever the issue may be, right? It's not going to get a lot of attention, probably, unless it's in the press or gets a lot of media attention, something like that. This is a numbers game. And so I think people really should take the time to do that. I do it every chance I get. Every time there is a new one, I don't do multiple, but every time there is a new letter to be signed onto or to send, I do that. And I do that as well. Sound, you may not know this, but we do provide comment letters to CMS on the proposed rule.
Yeah. That's good.
Yeah.
No, I didn't know that. That's great.
Yeah, they come
do
from
you
Dr.
think a phone
Bergmeyer.
call is better? I've heard phone calls that even have a bigger impact. Is that true necessarily?
If you want to take the time, SHM also does what's called a Hill Day. They actually have people come to DC and we set up meetings for folks with either their representatives or more likely the staffers. And when I first heard, wait a minute, meeting with staffers, that's kind of a bummer. I wanted to meet my senator, for example.
Yeah.
Meeting with senators is interesting, but you're going to get more airtime and really get more into the issues. You're more likely to with a knowledgeable staffer. And some of the folks that staff these federal offices are amazing. Wow. Absolutely amazing. I met one, won't mention her name, but who had participated in the creation of MACRA, and she knew this stuff inside and out. She was an attorney and a physician. It was just amazing. Wow. I just sat in awe of the policy chops that she had. It was impressive. But wow. There are a lot of staffers that are just very knowledgeable in the healthcare space. Whereas it's not that like a senator or a representative isn't, maybe less in the details, but they have less time and they definitely have a lot of other things in their mind.
I see. Okay. So everybody, write your Congress people, write your senators, write your representatives, and tell them that maybe not WTF, but tell them that this is just not
If you're concerned about payment, I think that's an issue they're very familiar with.
And
I don't know about whether a phone call gets the same attention. A phone call, if you're requesting a meeting, probably does. And you can always meet with your state representatives, although I think that's less likely. This is a federal issue. I think that's less likely to be meaningful.
And just tell them that it's not about greed. It's about practice sustainability. We just can't stay in business if our costs go up and our revenue goes down. It's just
healthcare businesses are low margin to begin with. And
they are
chipping away at it.
It really is. And
staff won't work for free. Nobody works for free.
Nobody works. The lawyers don't work for free. Neither do the Congress people. They don't work for free.
Right.
So, so definitely advocate on behalf of our field and just tell them that this is not sustainable. So definitely everybody write your Congress people. As a physician advisor, so health policy or physician advisor, what kind of advice do you give practicing clinicians from your perspective as a, and just for those who don't know, maybe explain what I know. I'm a physician advisor. Explain kind of what a physician advisor is. I think this is something that's relatively new in the healthcare space.
Yeah. It is a new specialty or subspecialty, if you will. It doesn't have an official designation as a specialty, but folks that actually
there is a board. You can actually get boarded.
Yes, there is. There are certifications, more than one actually, and that's not surprising given the fact that it isn't one. I think most people that work as physician advisors come to it from an internal medicine or hospital medicine background. But there are a lot of emergency medicine physicians, critical care as well. You kind of have to know hospital care to be any good at it, in my opinion. I'm sure there are exceptions, but we've had candidates that were radiologists or something, and unless they were really stellar clinicians in their training and they're not that far from it, I think they're going to have a hard time understanding all of the medicine involved. So basically, an advisor can do a lot of different things. They are a liaison between hospitals' case management functions and the medical staff, for example. They help determine whether cases are appropriately inpatient versus under observation. And there's a large difference, about $6,000 per case for the hospital in that. And it's in most cases, it's less expensive for a patient also if they're an inpatient. It sort of depends on how long they were in the hospital, but they interface with payers, and that can be very time consuming when payers deny cases that should be inpatient, and they have to get on the phone and have what's called a peer-to-peer with a payer physician typically. And so it really depends. They can do a lot of different things, but essentially they are force multipliers in revenue. I wouldn't say generators, but they help the hospital collect the revenue that they're owed. And that they're due. Yeah. For
my role, I used
services that they provide.
I used to be, well, a physician advisor would sound, I used to do level of care reviews, which would say this is more appropriately inpatient versus outpatient. The way my practice and the way my life has changed, now I'm writing appeals. So post facto, the care has been denied, and then now I'm writing the appeal letter. I really enjoy doing that. I especially do DRG appeals, which are, and I think we're going to see them. I saw this on LinkedIn by Ronald Hirsch. Ronald Hirsch, I don't know if you know him personally. He was saying because Medicare Advantage plans are losing more money because of the changes in the rules. Finally, you're going to see a lot more DRG denials where they're going to go back and say, this patient didn't have type 2 MI. It had nothing to do with it. So we're just going to deny that, and you owe us $5,000. They're going to do a lot more of that. And I see that now. I'm fighting those, and I'm denying those, and I'm writing appeals for those. I love doing it. I have to tone down my sarcasm sometimes.
Knowing you, that is hilarious. Yes.
I have to really... Yes. I have to try to
yes, you do.
I have to try to be a little bit professional, not just say WTF. I've never typed that because I have to type them.
Of course not, right?
But I want to. I want to. But I think I think it's what as a physician advisor, what advice do you have for practicing clinicians in order to improve kind of like what's the number one pain point do you see as a physician advisor?
Well, so I mean, generally physician advisors are working for hospitals or health systems, and for the most part, this is hospitals, not so much in the outpatient space, although that could the field certainly could branch out in that direction because there's a lot of work. I think of physician advisory as one way to do applied policy. Essentially, that is what it is. If you understand the 2-midnight rule and you understand the commercially available guidelines, Milliman care guidelines and interqual, and the way hospitals use them and why they use them that way and what utilization management procedures are and what the plan is. And if you understand all of these policy elements and why hospitals do what they do or how they do what they do, it's really just about applied policy. I think for practicing physicians, particularly as we talked mostly about reimbursement issues, it's probably the bigger bang for the buck is in compliant documentation according to the guidelines that, depending on whether you're outpatient or inpatient, 2021 or 2023, it's the same table. It's just that the medical decision-making table changed in those years in the different care settings. It's the same table used by all care settings now, though. And I think for the individual practicing clinician, there's probably more benefit there. I'm not saying don't pay attention to the needs of your hospital. And as a 25 years as a hospitalist, I could never say that. And I truly believe that wherever you are, whatever hospital or hospitals you're working at, you owe it to them and to yourself to improve the environment that you're in. That could be clinical, that could be financial for the hospital, whatever. All of those things are important. But in a physician's day-to-day, most practicing docs don't want to think about, is this an inpatient or is this an obs patient, right? One of the last times I did clinical, I was at a hospital in the Pacific Northwest, and I asked an older physician about this. Like I think I got a call from case management there or something, and I was getting excited about it because I have a physician advisor, and
Right.
I was probably getting animated, and she was just doing her work, not paying any attention. I've known her for a while, so I just said, Dr. So and so, what do you think about status? Like, what do you think? And she said, I don't have time for this expletive. Just tell me what to do. And I've thought about that for a long time. I think that really does encapsulate anyone working in a hospital setting, particularly as a hospitalist or critical care doc or ER physician. Your day is a bombardment of interruptions of important things and not important things, and you're constantly like stratifying, where do I need to be at what time, and I got an admission, like drop what you're doing and go deal with that. Status doesn't rise to the level of importance in that setting. That nobody went to school, medical school and residency, like, I want to learn status determinations, right? Nobody does that. It's interesting, and I really enjoy it, as you do as well. But it's not for everybody. I think my point is, for practicing physicians on that front, listen to your case managers, listen to physician advisors that may be trying to help guide status. If you have a different opinion, it's ultimately that practicing physician that's caring for the patient. Status is their responsibility. Legally speaking, from a Medicare point of view, it is up to the treating doc. If someone says, a physician advisor says, I think this is appropriate for inpatient, and the doc says, I don't think so, they're really just waiting for placement, and I haven't done my note yet today, so you couldn't see that. Totally fine. No physician advisor is going to get bent out of shape over the treating physician disagreeing, particularly if they've got a good reason for it, which they usually do. But yeah, focusing on, I think, more the physician fee-for-service billing and doing that correctly. I'm not seeing a lot of people that know how to do it very well yet.
They don't. I was about to say, most don't know that the rules have changed, and they're still doing the same because they just don't have time. They got to get the note done. They got to move on. They got to discharge. But I mean, they got to discharge by 11 o'clock in the morning, and then they got to get new admissions, and they got to get things moving along, and they got to do this and that. And there's so many things they just don't think about it. But I mean, I don't want to bring audits down on my colleagues. At the same time, everyone's doing it wrong. Like almost like so many people are doing it wrong, right?
Yeah, and
unless your practice is really into, like we are, really into making sure you're following the rules. Most other people, I think, don't even know the rules have changed, and they just think dumping 5 pages of labs is sufficient. It's not. It's not. When is the audit hammer going to fall? I don't know.
Yeah. So, I spoke with one of our auditing folks at Sound. We have mostly internal auditors, and it was her belief, mine too, actually. This is why I raised it. I said, the OIG is going to look at this at some point. This was a new change in 23 for hospital settings anyway, hospital places of service. Do you think they're going to look at this next year? And she said, I wouldn't doubt it. So I do think eventually the OIG will look at it. As to how firm they are.
And the OIG is the Office of Inspector General. So they're the ones that audit the bills.
Enforcement arm, and they can take back a sizable amount of whatever if they think that there's been overbilling. I have no doubt that they're going to just, their use software. I mean, I have no evidence of this, but like it's 2024. They're going to use software to look for billing patterns, and somebody that's billing all F3s or follow-up three, we call them F3s, but like the inpatient follow-up code is 99233. That's
the high level follow-up code.
If 100% of someone's charges are that, oh, they're going to stick out like such a sore thumb. I would love to work on the OIG team for that, because it'd be like such easy success, right? But if you look at the way the rules are written, the way the table actually reads, every patient every admission, every new visit being a high level, actually that's pretty standard. It's pretty reasonable, assuming that the ER physician spoke with the admitting physician. And if it's all documented properly, just about every admission has 2 or 3 labs, radiology, whatever, what's called category 1 in the medical, not to get too technical, but in the medical decision-making table, there's always, for admissions that go through the ER, there's always enough category 1 data to review. Right. And that discussion. And most of the time if you look at the MDM table, I know we don't have it here, but in the hospital, column 1 is the number and complexity of problems addressed. Low, that's not really a hospital setting. Right. Patients that have low column 1, that's really, they don't get admitted. And so we're really dealing with the other 2 columns, or the other 2 boxes, the moderate and high. And so it's, without getting too technical again, it's very straightforward that most admissions would end up being level 3 if properly documented.
Right. But
I don't know that the OIG is going to know that, because
they don't.
Because overall, you'd have to understand the table and how it works. Like, I'm talking about billing and documenting in a completely compliant way. They still would be level 3 most of the time.
Right. But
maybe they should be.
No, and I think they should be. If somebody comes into the hospital with pneumonia and they're have kidney injury and they're not, I'm not talking about critically ill. Those are very complex, life-threatening situations. They need to be high complexity. We just don't. I don't know that a lot of us understand that the rules have changed. I love them. I've been writing about it and podcasting about it. I love it.
Now, you were actually. I think of all the docs I know, I think you were out in front of it more than anybody. Like talking about it. You were asking. I remember you asked for audits using the new criteria for even like the end of 22. You were asking for feedback. Because
I was so looking forward to it. Finally, I don't have to do a stupid review of systems and put in 50,000 labs in my note. Now I can just focus on what I think is going on with the patient, which is why I became a doctor, and what I'm doing about it right at the top. And all the other stuff I just put at the bottom for documentation, but my assessments are now all narrative. As a writer, I like it, right? They're not even problem. It's narrative. The patient is critically ill with septic shock secondary to pneumonia. They also have kidney injury and anemia and thrombocytopenia. And my plan of care is the following: 1, 2, 3, 4, 5. Done.
You need to be careful about what's called linking. When you're bringing in labs, when you're talking about medications and their dosages, those need to be linked to a particular diagnosis. And so one thing I see sometimes, a lot of the work I do at Sound is meeting one-on-one with docs who have not passed audits, is I see that old style. I think I was trained to do it this way, where you list all of the diagnoses and then another paragraph is all of the elements of the plan.
That's how I was trained to do as well.
Yeah, that doesn't work anymore. Like clinicians should never do that, ever. Because if you have like acute renal failure and elevated troponin and cellulitis and whatever, and then everything down below is you're gonna
continue challenge.
You say something about the renal failure or something about any of the other diagnoses. If it's not clear to an auditor exactly what that was related to, it gets no credit.
Is that right? Wow.
Yeah, it has to. Those things have to be linked. So narrative is okay provided you're doing a different paragraph for each clinical diagnosis, or things that aren't really closely related. You can say acute respiratory failure / ARDS, right? I mean, these are
Right.
Yeah, to separate those would be a little weird, right? So there is some gray there, but I've seen clinicians actually throw things together. They're doing paragraphs, or problems, and then elements of the plan, but putting things together that make no sense. Like I wouldn't say I've seen it all. I've done about 50 so far. About 50.
You're welcome to look at my charts. You can go into my.
In this context, I am an educator and trying to help people. What I see more often than anything else is that every once in a while I do see somebody that I think is, look, you are just overbilling. But it's pretty rare, actually. More often than not, like,
we're scared to overbill.
Did you speak to any one of the 5 consultants on this patient that was septic? You probably did. And they said, oh yeah, I spoke to all of them. Like, well, you didn't get credit for talking to any of them. And that's the reason it wasn't a high-level visit. You did the work, you just didn't document it. So giving them some tips on how to document according to the work that you did in accordance with the new rules.
Yeah, absolutely. I think that's so important. Is there somewhere, I know our practice has internal, but are there any other places that I can post where people can look at these new MDM rules, the medical decision-making rules? Is it on the AMA or CMS? I mean,
so
where it's easily found?
I don't know about SCCM, but I do know that ASAP, American College of Emergency Physicians.
Sorry. No, I'm a member. I'm a select member.
I know you are.
Critical care committee. So I love the SCCM. I don't want to get in trouble. I'm just saying. Yeah.
So ASAP, the American College of Emergency Physicians, and the Society of Hospital Medicine both have MDM tables that take the base table, the table that CPT created, and modify it a little bit. It's not that we're telling CMS what to do, but column 3 of the table really should be thought of as treatment risk. It's the actual verbiage is more complicated. It's risk
very complicated,
mortality,
very
patient
confusing.
management. It's a little wonky, but I think of it as treatment risk, and that's how I coach people. What SHM, I was a part of this too, but what SHM did was really copying philosophically what ACEP did. They came up with examples that are commonly seen in our specialty of things that we would consider high treatment risk. For example, a patient with acute renal failure and severe heart failure. That's a very difficult situation to manage from a fluid status standpoint, or a patient that requires acutely requires antipsychotics or physical restraints because of, being encephalopathic, high treatment risk because of the underlying condition and the patient's risk to hurting themselves. There are several other examples there, but I think I would point people to those resources. I know the SHM one is behind, like you have to be a member to access that, which is unfortunate. I wish it was just sort of available. ACEPS is available, I think, without being a member. I've certainly
ACEP. Okay.
And they both SHM and ACEP have FAQs as well that go into great detail. I mean, I think the one that we built ours off of what ACEP had created. Not that we copied them, we modified it, but it was a great framework to start with, and we had their permission to do it. Was very grateful for that. But it was 27 pages or something like that. It is indexed, so you should be able to use it pretty simply. But a lot of great information in there. No,
that's great. That's great. So we'll post those resources in the show notes. So write your Congress people, document better, and just write down what you're doing. You're doing the work. You just need to get credit for it. Now, one last question. If I make a mistake and they audit me and I underbill or overbill because I forgot to document that I looked at the hemoglobin and the platelets and the ABG, am I committing fraud? Am I at risk of being accused of committing fraud? Or do they recognize that physicians can make mistakes, that we're human beings?
Yeah, I think there's probably
compliance about
it depends. It depends. I mean, if you're not systematically, I am not a healthcare attorney, and so what I'm about to say may be complete garbage that our chief compliance officer would just shake his head at. But My understanding of it is that if there is an audit and they're not going to, like, I've never heard of CMS paying you more because you underbilled, right? So I don't think that's ever going to happen. I worry less about that, but systematic over documentation, what they typically do, it's like a rack audit that hospitals sometimes get, where they take a percentage back. They say you overbilled by such and such a percentage, and then they extrapolate that into a larger patient population and then reclaim funds that way. If it was something systematic, or I've been at Sound for 18 years and been all the way through corporate integrity agreement. I have never, ever heard us encourage anyone to overbill at all.
Right.
Definitely document the work that you do, bill according to that documentation and the work. Those things should all align. That's always been the message. But I think if there was evidence that an organization was systematically overbilling or something along those lines, then yeah, I mean, a fraud investigation would be an OIG investigation, though, and I think that would be serious and concerning,
right,
for anyone.
Yeah, well, which is why a lot of people just don't want to deal with it, and they'll just underbill, and that's not fair. They don't want us to underbill either, if my understanding is correctly. They want us to bill the appropriate level, right?
Yeah, I mean, they're not going to penalize anyone for it, but yes.
I mean, but they want us to bill and we should get the credit for the work that we do.
Yes.
So, Dr. Rob Zipper, thank you so much for your time and your expertise. It was great to talk to you, and
you as well.
I thank you, and this has been very helpful, and look forward to more conversations with great minds in medicine like you. Thank you so much.
My pleasure.
Thank you for watching. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.